So you know, big impact there. Graft failure remains an obstacle for when using haploidentical donors, but I think we are getting beyond that. And what I'm showing you now is updated data, because one of the things that we know is that if you mobilize stem cells from the donor with GCSF, cytokine, you can increase the number of stem cells you transplant. And at least in hematologic malignancies, that has been shown to improve the engraftment rate. And too early to say that we have solved this problem yet, but I will tell you that we have done an additional 6 patients using this approach, and 5 of the 6 have engrafted, and are full donor chimerisms, most of them. So, you know, showing we've really crossed the HLA barrier here without graft versus host disease. So we're really excited about this. Future diseases. Genetic diseases of stem cells, sickle cell disease, thalassemia. Again, we really want to get this engraftment rate up to greater than 75% without increasing toxicity. Autoimmune disease, a lupus protocol is written, and you can really do a lot of neat things with autoimmune diseases, because in lupus, for example, we are prioritizing male donors over females. Why? Well, lupus affects women 9 to 1. So again, and it's more than just the hormonal factors and that are involved, and there's some good animal model to show that. In Crohn's disease, there are certain polymorphisms that predict a sensitivity to Crohn's disease. So we can take family members that don't have those polymorphisms. So there's all sorts of things that we can do to choose donors, not based on their HLA system, but whether or not their immune disease would come back. And again, this protocol is in the IRB right now, getting ready to start. This has been funded for a study, and the clinical protocol for solid organ transplantation will probably also start in 2013. So the take-home is morbidity and mortality following allogeneic bone marrow transplant is substantially decreased. This is because of better supportive care, reduced intensity preps, but most importantly, we're able to use post-transplant Cy to decrease the risk of graft versus host disease and cross-HLA barriers. Alternative bone marrow transplants are a reality, and virtually everyone has a donor. Bone marrow transplant for genetic disease, autoimmune disease, and solid organ transplant, I think, is the next frontier of bone marrow transplantation. And I just want to stop and acknowledge all the people that, and there's many more, that have contributed this, especially our nursing staff, our house staff, and the patients and families. And I'll take any questions.
Looking at your patients retrospectively, are you able to predict who's going to engraft, who's going to be successful and who's not?
Yeah, I mean, certainly the haploidentical patients are a bigger risk. It's something we hadn't had to consider before, but we screen these patients differently now. When you have a half match, only then do you have to start worrying about anti-HLA antibody. You didn't have to worry about that with matched siblings or even matched unrelated donors. So we screen them now for anti-HLA antibody and make sure. One of the patients that we didn't do of the 19 was because he only had one donor and had high levels of anti-HLA antibody. But again, we really designed this protocol built around safety. So graft failure, clearly not a desired outcome here, but with a non-myeloablative transplant, the patient doesn't die. They, their counts drop and they come back up and they recover their own hematopoiesis. They go back to having sickle cell disease, but at least we haven't killed a patient. So now we're trying to do techniques like GCSF mobilization. We may do pheresis of some of the donors to try and decrease that graft failure rate. And I'd like to get it up, as high. I'd like to get it 100%, but realistically, I'd like to get it over 75, 80%. And I think we can do that without adding to the conditioning regimen, which is going to cause toxicity. Yes?
I was wondering, can you do this in kids, and is it possible it could be more effective in kids since they would have had fewer transfusions? bone marrow transplant doesn't work, can you try again, or are there too many antibodies at that point?
So, great questions, and yes, and one of the things that I tell our nurses and our fellows who are, you know, they see this and they're just like jumping out of their skins because they're so excited watching this. I tell them enjoy it while it lasts because we're not going to be doing this long. The pediatricians are, and later this month I'm actually going to London to meet with a bunch of European centers that see a lot of sickle cell disease, and they primarily see pediatric patients with sickle cell disease, and they're also transplant centers, and we're trying to get to this answer a lot faster by collaborating and using the same exact protocol, the same exact parameters, the follow-up. So with, you know, now 4 or 5 major centers, we can get at this faster and not repeat each other's mistakes like is often made in the transplant field in the past, right? So, yes?
I don't understand the genetics of the diseases like lupus and Crohn's, but just starting back with sickle cell. With sickle cell, you need 2 alleles, right?
Yeah.
So if you have semi-matched donors in the family, you're not going to worry about reintroducing sickle cell from one of the donors. But
right.
With Crohn's or lupus, isn't that a possibility that your
Yes.
closer matched donors would maybe add trouble by giving back the thing you're trying to avoid? So would you then be better off going with a poorer match in terms of HLA, but a better chance of circumventing whatever the genetic disorder is that led to the lupus or Crohn's in the first place?
Right.
And do you know what you're doing with Crohn's?
Yes. So great question. So yes and no. So let me get at your first question. The genetics. The genetics is very complicated.
Yeah.
Because with Crohn's and sickle cell, and lupus and multiple sclerosis, these diseases have a genetic component, but they also have environmental components, and you know, sex plays a role in diseases like, especially diseases like lupus. So we don't quite understand all of that, but let me tell you 2 things. These are acquired, not purely genetic conditions. And even amongst identical twins, the concordance rate for most of these diseases is 25% or less. So most of the family members aren't going to get the disease. We are starting to be able to pick apart the genetics and at least susceptibility to them, and to pick donors that would be less likely to acquire that disorder, number 1. Number 2, I will tell you that just like in sickle cell disease, there are probably scores of patients now that have had a known autoimmune disease, Crohn's disease, lupus, rheumatoid arthritis, psoriasis, myasthenia gravis, etc., that developed a hematologic malignancy and got a fully matched HLA identical bone marrow transplant. And in virtually 100% of those cases, if the patient survives the transplant and is cured of their underlying hematologic malignancy, they're also cured of their autoimmune disease. So I think that the chances that we can cure a large percentage of these patients is pretty realistic.
So you don't really care what's curing, what the cause of that autoimmune dysfunction is. You're just going to you're going to override it by adding in.
We're going to reformat the hard drive.
Yeah.
Yes, and by putting in a new immune system. Yes.
Just quick questions. When you're looking at these patients, are you looking at infants under 12 months? And 2, if you could just review for me, I know you explained this, but the relapse question, patients who have malignancies will relapse, so patients who don't will not. Did I get that right? And if so, why is that?
So it depends on the underlying cancer. So if you take a leukemia patient who is in a first complete remission, so they develop leukemia, you give them chemotherapy, you put them into a complete remission, and because of certain things that we can tell about their leukemia, their genetics, etc., they have a certain type, we can say that, yeah, maybe about 50 or 60% of those patients are going to be cured by an allogeneic bone marrow transplant. If you take someone who doesn't go into remission or who is in a second remission, the numbers drop substantially, maybe as low as 25%. And so we can tell who has the higher, we can stratify risk that way. The reason is because the cancer cells, even with an allogeneic bone marrow transplant, are not always eradicated. You don't always get every last one, and the cancer stem cell has an advantage over the normal stem cell. In sickle cell disease, we see something very interesting. So one of the things that we follow in these patients is their chimerism, the percentage of donor and host cells. If we see someone with leukemia or myelodysplastic syndromes, all of a sudden show mixed chimerism, we're done. We know. Relapse is coming around the corner because that small population is going to become a large population, and these patients are ultimately going to relapse. In sickle cell disease, it's interesting that some of our patients remain mixed chimers. So they still have some host cells at the level of the white cell or the lymphocytes. But if you look at the level of the red cells, they're 100% donor. And again, it's the transplant working in our favor. Here, the normal cells have the advantage over the sickle cells, right? So even mixed chimerism is enough to cure the disease in many instances.
Could you remind us what chimerism means?
So chimerism basically tells you, so we basically take the blood cells, and we can tell just by polymorphisms what percentage of the cells are host, the patient, and what percentage of the cells are donor.
And do you use baby stuff too?
Oh, so we've probably not ideal to use infants. Probably the ideal age to do this is somewhere between 5 and 15 years old. Remember, not everyone with sickle cell disease has severe sickle cell disease, and sometimes patients start off with pretty mild sickle cell disease, and only as they get into the teenage and adult years do they develop severe disease. And there are certain things that predict for poor outcome that we use as entry criteria in this.
Well, thanks a lot, Rob. I think we're